Next speaker, Professor Hisham Haggag, Assistant Professor of OBGYN, Cairo University, a dear friend and colleague in our session, and he's going to talk about the changes in practice in university hospitals in Egypt in the COVID-19 pandemic. Professor Hisham.
Thank you very much, Dr. Khaled Rashid, for this wonderful presentation. I know we're running short out of time, so I'll try to be rapid, just highlighting the key things that we had done in Cairo University Hospital and the other 6 major university hospitals in Egypt. I would like to take the opportunity to thank Professor Ihab Suleiman for allowing us to share this work. It was supposed to be presented last year, but unfortunately the conference was put off. But thanks God, we have the time to tell you what happened in the early pandemic period and share our thoughts with you. Until the presentation gets ready, let's all agree, as Professor Wieser said and Professor Di Renzo, that we are still in the fog and we're trying to put the pieces of puzzle together. There is an old saying that says 50% of what we know will be proven wrong in the coming 10 to 20 years. But unfortunately, we don't know which half will be wrong. So we are still trying to take baby steps in this devastating pandemic. No solid guidelines, no consensus have been approved for many of the issues regarding maternal and child health. So today we are going to discuss the changes in OB/GYN practice in the Egyptian universities during the COVID-19 pandemic. Sorry for this technical issue. This is why I asked them to be presented from my laptop, but they insisted of using their own. So let us take just a moment of respect for the doctors that we have lost during their fight in the COVID-19 pandemic. Let's take a moment of silence, please. Thank you very much. I'm sure we've all lost colleagues and family members and beloved ones in this devastating event. But the most hurtful to us were our colleagues that were fighting this devastating pandemic. We have more than 500 Egyptian doctors that died from the COVID pandemic performing their duties, and we should not forget them. They will always remain with us in our hearts. So we're not going to talk about what is COVID or what is the treatment. I'm sure Professor Catherine Nielsen-Percy had discussed this, and we all know about this condition, but we are going to talk about why do we need a change in the practice. Since its outbreak in Wuhan, China, the ongoing pandemic of coronavirus has become devastating, and despite implementations of extensive control measures, it has rapidly spread to all over the world. It is important to realize the logistic hurdles associated with medical supplies and strategies to accelerate and mobilize and optimize the different health care facilities. Here in Egypt, we have limited resources, and we should understand this, and this is one of our main strategy was understanding what do we have and what could be done to face this pandemic. These measures are crucial for controlling the disease spread and protecting not only the patients, but the healthcare providers, and acknowledging such potential associations of mortalities with healthcare resources and strategies might aid the world to be better prepared. Till now, we are not sure 100% if COVID-19 affects pregnant women more than the other population, but we are sure that pregnancy alters the immune response, and there is evidence that such women are at risk of developing more complications. So what is our story in brief? Well, Egypt announced the first case of COVID-19 to appear on the 14th of February 2020, and even before the appearance of this disease, the official bodies have had plans and strategies to face the growing worldwide disaster. What about Qasr Al Aini Hospital? For all of you who don't know, Cairo University Hospital comprises more than 5,200 beds and is being the largest medical institution in the Middle East and probably one of the largest in the worldwide. And ever since its foundation on the 11th of March, 1827, Qasr Al Aini has been considered the stronghold of science and culture for us. And the obstetric and gynecology department is one of its main departments. We serve around 100,000 cases per year with about 15,000 deliveries per year and almost 300 surgeries and procedures. We conducted the study, which was a retrospective study over a 3 months period, and we collected data for the numbers of attending cases, admitted patients, and how we manage such patients and infected cases, not only on the, among the patients, but also among the healthcare providers. We took data from Qasr Al Aini, my institution, Ain Shams University, Alexandria University, Manufaya, Tanta, and Minya. And we looked at the earlier pandemic period from the 1st of March 2020 until the 31st of May 2020, and compared it to a previous period from the 1st of December 2019 until the 28th of February 2020. We were sure, of course, to take the data and collect the data privately and remove all medical and non-medical personal identifications. Now, our efforts were part of a huge effort from other hospitals among Egypt and not only university hospitals. And we started collecting all the official documents that were issued from the deputy manager of the OBGYN hospital at Qasr Al Aini to implement what strategy should be done during the pandemic period. Our strategy was simple: no more than 6 patients to be present at any time in the triage, so limiting the number of patients triage. We increased the number of halls serving the patients to 5. We allocated a specialized, staff member, a lecturer, to follow and implement such strategies. We had adequate spacing between the patients with different tracks for suspected and confirmed cases and non-suspected cases with COVID-19. We used different words, and we did not change the admission criteria, but we had to change our discharge policies. For example, vaginal deliveries were discharged earlier, and cesarean sections were discharged earlier than the pre-pandemic period. We had personal protective equipment, and we did PCR for most of our admitted patients. And of course, we are a teaching hospital, so we had to include hybrid learning and implement strategies for such learning to avoid contact between the staff members and the students. So what are our results? We found that we had a drop of 11.7% and 26.7% in both the attending and admitted cases in the emergency department. And this was statistically significant when compared to the earlier pre-pandemic period. However, there was no significant change in the percentage of patients undergoing different procedures. For vaginal deliveries, cesarean deliveries, ectopic pregnancies, postpartum hemorrhage, there was no difference statistically between the pre and post-pandemic period. However, we also noted there was a slight skew towards cesarean deliveries at the expense of vaginal deliveries, but this was not statistically significant. Possible causes for this: that uncomplicated pregnancy might have sought home deliveries or closer facilities for the fear of getting the COVID-19 virus. The main problem or the main drop was in the elective admissions, both pre and post-pandemic. As Professor Ganzo just said, that it affected women's health. We had a sharp drop of attending cases to the gynecology outpatient clinic, and even the admitted patients dropped significantly, almost 75% decrease between what was done before and what was done during. Of course, this would affect not only the maternal health, the women's health here in Egypt, but it will also affect the learning of our residents and our trainees. And this was statistically significant. So what did we do to tighten infection control? We had to decrease the number of service providers to optimize our level of staff and minimize staff-to-staff exposure. So when we calculated the change in the number of service providers, we found that we used less number of residents per shift, less numbers of nurses per shift. The most drop was in the nurses, and this was to decrease staff-to-staff transmission of infection. So maybe they had to work longer hours, but they took less number of shifts to decrease the risk of spread of infection. The capacity of the obstetric and emergency department increased during the pandemic period, mainly to accommodate for any emergencies that our hospital would face. We allocated more beds and halls, rooms and theater post-pandemic than in the pre-pandemic periods. And we also had more isolation ICUs and non-isolation ICUs. And we also increased the adequate spacing between beds to 3 meters. What about other hospitals? We had 6 major university hospitals. They used similar approaches, aiming to decrease and improve preparation. And this resulted also in decreasing in the attending and admitted cases, except for one hospital, and I will tell you why in a moment. As we see in Ain Shams University, there was almost a third of the drop of the attending cases to the emergency departments, which was similarly found in other hospitals, but not Alexandria. And the admissions also were decreased in all other university hospitals, even Alexandria Hospital. And we had to look what could be the explanation for such a difference. And we found that Alexandria is the major university hospital covering the North Coast, and that during the curfew, most of the private centers and other hospitals limited their number of admissions. So Alexandria was doing a great job in facing the pandemic as the other hospitals. I'm sorry, the table is not clear. The most decrease was found in Ain Shams University, where there was a 34% drop in the attending cases as compared to Qasr Al Aini University. And we also noted that there were around 60 to 80% reduction of elective cases when combining all the data together, with Menofeya Hospital having the strongest reduction, only 1 case to be managed during the 3 months period of the study. As you can see here in this graph,
women having cesarean sections,
a third of the workload for elective cases was found in the attending, and even more, a fourth or a fifth of the cases were managed for elective procedures. I'm sure this would affect women's health, and this would affect also the training of our trainees and residents. What was the outcome during the first 3 months of the pandemic? We had 8 in Qasr Al Aini, we had 8 cases of COVID cases admitted, 1 mortality, 1 neonatal mortality, and 38 hospital staff member infection. Even though we had strict precautions, we had 38 hospital staff, healthcare providers infected, mainly in the nurses, which were in more contact with the patients than the residents and the house officers and the clerks and the workers. Similar outcome was found in Ain Shams, with 72 staff member infected and 1 case of COVID patient was admitted, and most of the healthcare providers were from the nurses. Fortunately enough, in rural areas, they were more protected, and there was only one case of COVID-19 admitted in Menofia with no ICU and no mortalities, and only one staff member reported in Minya during this period, which gives us the idea that they might have been protected during their geographical location. Now, according to the CDC guidelines, each healthcare facility should consider their space and staffing needs to prevent transmission of COVID-19. Consideration should include proper isolation of parturients who are suspected or confirmed to have COVID-19, as well as proper training for all healthcare providers. The working staff should clearly adhere to infection control measures and proper usage of PPEs or personal protective equipment and disposal, in addition to having access to sufficient supplies at every point of care, not only during the admissions, but also during the triage. When we compared what was done to such guideline, we found that there was a good initiative to decrease the crowding to ensure proper spacing and prevent disease spread, as well as good management of human resources to avoid overworking and exhaustion. Till now, there was no report on how obstetric practice should adapt to the pandemic, and no key performance indicators have been described to objectively measure or demonstrate success in disease control. Yet our infection rate was comparable to what was described by Penna et al. In 2020 in 4 major university hospitals in New York. What were the limitations of our study? Unfortunately, we could not adjust our observations seasonally. The first pre-pandemic period was in the winter, the other one was in the spring and early summer. There was possible distortion also due to the presence of the holy months of Ramadan in the pandemic period, which also affects the workload. And focusing on the early months of the pandemic might have had underestimated the actual infection rates. Finally, I hope that this by sharing such policies, we will help simplify and direct optimal care for COVID-19 obstetric patients, especially in low-income or middle-income countries. As we said earlier, we have to optimize what we have and what could be done with the facilities that what we have. Thank you very much.